India's best known palliative care specialists and advisors. And she is a chest physician, a respiratory physician. And she has been on our sessions at least twice, if not thrice. And once with Dr. Sujit Rajan, and the other time with Dr. Roop Kusani, talking about palliative care, what it means, and what it, what are the possible things that one must do if one is into a respiratory ailment, or if one has somebody has dementia or any other neurological ailment that we had looked at when we had Dr. Iyer as well as Dr. Roop Kusani. So Dr. Iyer is having a problem connecting, and sorry, you need to bear with me for this. She is joining us. She says in 2 minutes, but she's not able to join. And as always, we don't like to keep you waiting. So we started at 5 sharp. May have been a few seconds after 5. So before, even as we wait for Dr. Rajam Iyer to come in, if you have any comments on what we should be doing at with our Health Live webinars, any specific health condition that you think we should be including, please let me know. Put them on the chat window. If you want to talk, I can allow you to talk over here. If not by video, at least by voice. Please raise your hand, and I will patch you in for a conversation. Let us do that. Okay, so you have Mr. Deepak Shroff, who's there. Yeah. Yes, Mr. Shroff. Boliye. Mr. Sham Mittal, my voice is... Dimple, can you hear my voice clearly?
Hello.
Yeah, Mr. Shroff, boliye.
Can you hear me?
Yes, of course, we can hear you very well. And
now, my suggestion is we should have one session on the full body checkup of seniors also. That would really help senior citizens. If full body checkup session is there, it could give a better idea to a senior citizen what is the benefits of.
I appreciate. Yeah. All right, sir. Thank you very much. So let me just disable the talking. So basically, we've had this in the past, but I appreciate what you're saying. So we will have an internal medicine specialist coming in sometime, and who will talk about the entire issue. I have to talk to the doctor because she's not able to get across. 1 second. Hello, yeah. So the good news is that I was just speaking with the doctor, and she is going to connect perhaps from the mobile phone because she's not able to connect from the from her laptop. So we will be there. Yeah, she's here. Hello.
Hi, good evening.
Good evening. Good evening. So I was just talking to. So I'll just finish this conversation. So Mr. Paliwal, insomnia or sleep maintenance. We've had somebody on sleep in the past, but I will note down this point and remember. And we have Mr. Suresh Kate. I suggest to have a session on neurological problems because senior citizens mostly have hypertension issues, forgetfulness, headaches, etc. I agree with you. So we've had neurological issues in the past. In fact, once when Dr. Iyer was here, we had Dr. Roop Gursani, if you remember. So he was there, and but we will have him or somebody else again. Without any further ado, let me welcome Dr. Rajam Iyer.
Good evening. Sorry, I was also trying to log in through the computer and it's kind of misbehaving.
It's you'll have to allow me to introduce you, Dr. Iyer. She is, as you know, those of you who have been attending our sessions for a while would have interacted with her perhaps at least a couple of times in the past. And Dr. Iyer is a leading chest specialist and a palliative care physician. She's attached to the Bhatia and Hinduja hospitals in Mumbai. She has been, she's worked at various places, Godrej Hospital, the Chest Research Foundation. She completed her MRCP in the UK in 2007. She's been a lecturer at the Sion Medical College for many years. She was a recipient of the Hargobind Foundation Fellowship in 2002, and she has been affiliated with the Indian Association of Palliative Care and Indian Chest Society. And apart from that, she has, written a host of publications, etc. Great. Am I seeing you something wrong with me, Dr. Iyer, or am I seeing two of you?
No, so I thought I was trying to log in with the computer and now I've managed to successfully do it. So I can, in case one goes off, I know I can use the other.
But you are now connected on the laptop, on the mobile.
Yeah, correct. So if I'm audible and I'm clear, we can continue on this.
But the laptop was very good.
Laptop was better?
Yeah, we could see more of you.
Okay. Fine. I can log off this and then we can start the session.
Yeah.
Yeah.
Yes, great. So,
yeah.
So welcome to Health Live at Seniors Today. How have you been?
So far, so good. It has been quite a recovery from the COVID times. I think the world has opened up and so has work picked up, and we have now started going to hospitals more regularly for non-COVID work. So yes, in that sense, quite busy. And I think the rest of the responsibilities at home, caregiving, senior citizens, etc., keeps going on. Since once a family is such that the average age on both sides is about 75 plus, there's never a dull moment.
Tell me something. I want to ask you something on a lighter note. And
yes.
Since I've known you for a while, for many years, I can ask you that. When you say work has picked up, when a doctor says work has picked up, what does it mean?
So multiple things. I think during COVID, there was a lot of apprehension even from patients to report to hospitals in the fear of getting COVID or, not or probably reporting to a hospital where they will not be attended to, because a lot of non-COVID work was stalled by hospitals. So elective surgeries like knee replacements, shoulder replacements, hip replacements are all not being done since we had to use maximum hospital space for treating patients with COVID. So now that the number of COVID patients, or the fact that we all have had our third Most of us have had our third dose, which is the booster or the precautionary dose, as called in India. Now people are a little bit more confident. As you can see, even during the Ganpati festival, people were out and about. There were crowds everywhere, and also people are without masks, which according to me is not a great idea yet. But having said that, people have got more confidence in getting out, and therefore they're also coming and reporting to hospitals. And therefore, I think the health-seeking behavior of patients has increased, and that's why work has picked up.
And tell me, but along with COVID, now you have H1N1, you have dengue. So it's not just one thing, and then in between there was this also the fear of monkeypox, which came in. So it really looks like we've had multiple back-to-back pandemics or threats of pandemics.
No, so I don't know whether it can all be called to the proportion of pandemics. H1N1 has always been there. It's been there for probably 100+ years. The point we must realize here is that our population also is living longer. So therefore, I think what happens is, since you have an aging population, their immunity is low, their vulnerability is high. They above the age of 65, they all do suffer from one or more chronic illnesses. And that's why that population, I think, needs to be careful about infections like H1N1. And it's important, therefore, to get the annual flu vaccine every year around the time of August, when the monsoon kind of recedes a bit and the temperature variation is seen between monsoon and hot weather, which is very typical for flu infections to rise. At the same time, because of festivals in India, there's a lot of crowding, there's a lot of social gathering, and it's easy to spread these infections. So above the age of 65, I think not very many doctors as well as people know about adult immunization, like it was popularized in earlier on about pediatric vaccinations. It's important that all adults above the age of 65 get vaccinated for flu every year and vaccinated for pneumonia once in a lifetime above the age of 65. It's very, very important and crucial, because we can only prevent what we can. Some things are going to happen, but the point is we need to exercise caution. And I would still recommend senior citizens to avoid crowded places, and whenever they do go out, say in a lift or a taxi or a public transport, to definitely use the mask, because even other respiratory infections can be filtered, not just COVID, and probably even pollution.
It looks like mask is going to be a way of life for us, is it?
See, I think, what we need to realize is, because of the 21st century, we managed to get a vaccine within 1 year of the pandemic. So I think in that sense, we are lucky, but you really don't know the variants, etc., that will come. And we still don't know much about COVID. To be honest with you, we are still losing lives with COVID. It's not that people are not dying at all. So, and it is definitely a milder infection. It's not taking patients to the ICU, but yes, to the elderly, it is still a infection which can become, which can lead to more morbidity and mortality among senior citizens.
Dr. Iyer, we've had you in the past, and we've also had a couple of sessions by Dr. Eric Borges, who had spoken about, introduced the Sukanlaya Center that he heads in Mahalakshmi.
Yes,
we've spoken about palliative care, but tell us, because as we know that our readers, our viewers here would also like a refresher, and of course, if there are any latest trends in palliative care that you would talk about to the people who have gathered here and who will watch it.
So I'm very happy, Pradyuman, to actually address queries and questions that people have about palliative care. I think somehow the word palliative puts people, off interest, or they feel it is when we are talking of end of life. And that's one of the things that we really want to strongly, kind of advocate and say that what we in palliative care would like to call it is more supportive and comfort care. And most importantly, that palliative care is a need-based medical service. It is irrespective of diagnosis, and it's irrespective of the prognosis of the illness. Historically, since it was started for patients with advanced cancer, somehow over the generations, it is misunderstood that palliative care is only for cancer patients and only for cancer patients towards end of life. Enough research has been suggested to see how the integration of palliative care early on in any chronic illness and also during the COVID pandemic has really improved not just the patient's quality of life, but overall the support that the caregivers give, the compliance of the patient, the optimum utilization of health resources, because patients are aptly supported at home. Patients are aptly kept comfortable at home, especially in a chronic, incurable, progressive illness. So it's very important. I think we have learned a very hard lesson during pandemic when there were so many senior citizens on their own. They could not seek help in hospitals because hospitals were full of COVID. Doctors were scared to visit home. I think it was extremely important there to actually support not just their physical well-being, but also their mental, social, financial well-being. And that's exactly what both the definition of health is not just the mere absence of illness, as well as what palliative care wants to do is look after a person in totality. And that's why it's a multidisciplinary team, which not just not just has doctors, but it also has nurses, physiotherapists, counselors, psychologists, psychiatrists, as well as volunteers, social workers, so that the person is felt supported in a holistic manner, and which is what we want to advocate. And one of the centers that Dr. Eric Borges actually runs is one of the things that all of you must try and go and see. It's a beautiful place which is kept for patients who are not able to be looked after at home, and their focus is also those patients who do not necessarily have cancer, and they can be kept with dignity and respect that I think each and every individual and human being deserves it, and it is their birthright to be treated as per their choices, aligned by their wishes.
I would invite people to ask questions, but I have a few questions which have come to me by SMS. The question is, let me rephrase it. At what stage one must look at palliative care?
So this is a very interesting question, because I think what happens is if a doctor talks or starts discussing palliative care early on in the trajectory of the illness, patient loses hope or doctor feels it's like giving up. It also we need to realize that palliative care is like a narrative medicine. It's like the way the communications and the difficult dialogues we have with the patient and the family is like doing a procedure. How we kind of untie and kind of tease out all their apprehensions and queries, that we are not talking of death. We are talking of quality of life till death. What one must remember is that death is inevitable, but a bad death is avoidable. So, for example, suppose you see the way now what is full on TV the past 2 days is the death of the 70-year-old monarch in Great Britain. And if you see the manner in which she died, we need to sit back and think of how are our senior citizens, the grand old citizens in this country, dying. This lady was unwell. You saw how it was. She was in her house. Of course, I know she's the queen, so probably the hospital her room can become a hospital room. But none of that was done. She was not subjected to futile, aggressive medical treatment, which is equal to life prolonging treatments. She was given the dignity and respect that she deserved at 96, because like most of the interviewers also asked, this was expected at some point. Still, it is so sad, or people are grieving. So obviously, death of any human being is going to be sad. It is a social loss. It is a personal loss to people who have lost that particular member. Having said that, at 96, you should not, everybody should not be shocked that a person is unwell or is going to die. The point I'm trying to make is, with all our senior citizens, already it is what I'm saying is they are thinking about the manner in which they may die, the situation in which they may die. And we need to encourage conversations around death and dying, because that is going to happen. Just like people are comfortable to talk about financial wills, I will leave this much to my daughter, this much to my son, people also need to have the the ability to have conversations of how I would like to be treated when I'm sick or in an emergency. The elderly people need to have that conversation so that we give them what they want us, and we give them and treat them the way they would like to be treated. So it's very, very important that it is difficult. Culturally, in India, we do not talk about it. Having said that, in most religions, it is accepted part of life that this is the way life goes on. That's the reason why also the COVID pandemic, which brought death and dying into such sharp focus. We had people walking into hospitals and never going back, or elderly people who are coming and they had no clue what was happening because they were in a strange place. They were watching patients, doctors in PPE, family was away. It was absolutely heartbreaking to see patients struggling alone in the ward without any loved one around. And hence, it is very important that we should talk about this, chalk it out as to what all needs to be done when that person is in an emergency, so that we do things which is comfortable for that elderly, reasonable for that elderly person given the chronic illness and obviously the condition of the patient. But it all depends on the needs of a human being. Palliative care is need based. Some people cope with cancer, some people don't cope with cancer, some people don't cope with illnesses like chronic lung diseases or say dementia. The caregiving can be challenging in patients with dementia. So there are so many aspects of healthcare which we in medical school tend to ignore because we are only trained to save lives. And there's way more to saving lives in a patient or in a family who has a patient with a chronic illness. The whole family balance is lost when there is a patient to be cared for. And especially in India, because healthcare is 80% out of pocket expense. It's very, very hard on patient, lower socio income, lower socio-economic people to keep spending that kind of money and not get any support psychologically or even socially for looking after their chronic illness. So there's a whole aspect of medicine that is not taught to us in med school. One being communication, two being, focus on what the patient wants. I really would like to ask my listeners, how many doctors actually say, can you tell me what is your choice? Or I would like to do 1, 2, 3, 4. What are your thoughts? Or are you happy for me to do this for your health? It's never, very rarely do you have doctors who sit and ask you, is this okay with you? It's always, in my experience, we should do 1, 2, 3, 4. You should take 1, 2, 3, 4. You should do all these things and come back to me. Are you okay with it? Are you comfortable with it? Will you be able to do it? Is something we really need to start asking our patients.
But Dr. Iyer, the thing is that when a patient goes, when a patient, the patient-doctor relationship is such that you can't, you don't expect the doctor to be, you can't tell the doctor that, listen, please ask me these questions, right? The doctor should herself or himself be asking these questions. So, as we've discussed in the past, somewhere the training process or the entire processes that are there in hospitals need to change, because they need to then have a solution available as an alternative about palliative care. So, in your estimate, how many doctors are really aware of palliative care and they're evangelizing? We've met two doctors here along with you, Dr. Sujit Rajan and Dr. Roop Gursani, and it's been over a year since that has happened. How many doctors would you say, in terms of pure percentage terms, who have embraced palliative care?
Hardly. I would think in India we probably have about under 1,000 palliative care specialists in the country. For a population of 1.3 billion, very, very few doctors. And I think the biggest problem for advocacy of palliative care is doctors. Doctors are the ones who are our obstacles because they really think palliative care is giving up. And we really therefore need to change the training. There is hope that the doctors which will eventually come out in the next few years will be different, because they have started including in the curriculum Attitude, Ethics and Communication Skills from September 2019. So undergraduates who join medicine are taught how to talk, how to break bad news, show empathy, express compassion. It's all very important for us to realize that these also are important to become good doctors. When you listen to the patient, when you empathize with the patient, that yes, I can see that this is distressing. I can't even imagine how you're looking after your mother and father when both of them are 90 plus. It must be completely exhausting for that person to carry on with his own life, his job, look after his children and his elderly parents, and have the life of a 50-year-old or a 55-year-old. So I really hope that in the future, doctors who are going to look after you and me, Pradyuman, are going to be more compassionate and empathetic. It's not important to know 10 causes of cough and 10 causes of chest pain. It's important to listen to the patient's story, and that's why it's called history. It's so important to listen to the patient, which very few doctors do.
Doctor, if I was among the 40 or 50 people, or actually a lot more who are watching it elsewhere, would be worried after hearing you, in terms of the fact that they're doctors whom otherwise they respect a lot, and they have they trust them. But what you're saying is that there are just 1,000 odd, or let's take 5,000 odd doctors in this country who understand and who appreciate palliative care, and if they find that their patient requires palliative care or requires some different kind of treatment, are not going to advocate it or advise it. So for our people who are there here, what would you advise? What should be their toolkit in case, God forbid, they have a situation where they might require more than just the regular medical advice? What should they be doing?
So first and foremost, I think, like you mentioned, is the doctor-patient relationship. I think a doctor who doesn't have the time to explain to you about your illness and inform you, it's very easy to Google search about illnesses. Suppose a doctor has given you a particular diagnosis. The next thing I know most people, educated people, do is Google search, which is not, I also do it for various things. Suppose if somebody has sent me some orthopedic problem or something, even I Google search. The point is that doctors need to give enough correct information to their patients so that they are satisfied that yes, I'm in control of what I know about my illness. So very often when I meet patients and I ask them, आप आपके बीमारी के बारे में क्या जानते हो? They have no clue, and they've been going to their doctor for 5, 6, 7 years. डॉक्टर साहब ने सिर्फ बताया कि ये दवा चालू रखना है, ये फेफड़ा कमजोर हो गया है. Nobody, see, the point is it's also the question of, if the patient starts asking too many questions, the doctor doesn't have the time. Point here is, if you indulge in effective communication, timely communication, explain to the patient in the language that the patient understands, which is different levels for different people, automatically the patient is informed and he can make his decisions. For example, if you tell a patient of, say, stage 3 or 4 cancer that the outcome of this treatment is low, side effects are high, you can do this, the percentage is only going to be this much, let it be the patient's choice. Doctor, I want to do or I don't want to do. You can't be talking medical jargon to people who will not understand, and then they say, doctor, aap hi decide karo kya karna hai. The doctor is not going to endure the treatment, because sometimes the treatment for stage 3, stage 4 cancer can be much worse than the illness. That patient who's able to talk, engage in some conversation with family, or eat some tasty food will suddenly become bedridden, in and out of hospitals, ulcers in the mouth, and imagine his quality of life before death. He's alive, but is he living well? And is that what he wants? So what I'm trying to tell you is, any illness, if the doctor explains in a language that is understanding by the patient and the patient and the family then has a time to process and analyze what is in the best interest of the patient, because the doctor doesn't know everything about the patient. So if you say COPD, if you say interstitial lung, which are chronic lung diseases, it is my duty as a pulmonologist to say, I'm only treating your symptoms. I'm not curing your lung. And there will be a point in time when all the treatment I'm giving you is not going to work. And probably the next step is going to be intensive care and putting you on a ventilator. Is that what you want? I'm not telling you to do this conversation in the first day. You have to build a rapport. You have to communicate with the patient. And again, the interesting part about private medical health care is time. Obviously, the more number of patients the doctor sees, the more money he makes. That busy consultant doesn't have the time to handhold you, and that's why the integrated palliative care helps. Because those patients who do not seem to cope, or who have too many questions, or are anxious, or who are needy, you can easily refer them to a palliative care team and have a shared care where the pulmonologist looks after the lung, or the oncologist looks after the cancer, the neurologist looks after the condition, and the palliative care team supports the patient and the family through all the trials and tribulations. Should I admit the patient? Should I feed him khichdi? Should I feed him this? I mean, he's not past stools. See, there's no time for the hospital consultant to answer all these small things, but it definitely makes a difference to the quality of life of the patient, especially when I am looking after my 84-year-old mom. If she's not past stools for 2 days, I know the amount of trauma she undergoes, increasing the dose of clemafin, scared she will wet the bed. There's so many things going on. And for the caregiver, it can be quite challenging. And these things are probably beyond the purview of hospital consultants, yet it is definitely directly proportional to the quality of life of the patient and his family. So it might be very trivial, but it's very important for these people.
Doctor, how does one locate a doctor who would be, who would look at, who would be palliative care literate and who would advise this to a patient? How does one locate these doctors?
Well, we do have a website of Indian Association of Palliative Care, and depending on the area and the geography, there are palliative care centers across the country. Yes, but also a lot of them are tuned to look after patients with cancer. Having said that, the ethos and the principles of looking after cancer patients and non-cancer patients are the same, because human beings, the needs are the same. It's comfort, dignity, respect, and obviously quality of life. So irrespective of the fact whether it's cancer or non-cancer, the needs of human beings are the same. So there are, on the IAPC website, I can definitely share the link with you. There are centers which have palliative care, but the most important thing is I don't see a rise in utilization of palliative care service unless there is a demand. So just like patients, 20 years ago, patients would have not thought, or 30 years ago, patients would have not thought of knee replacements. Now we have patients going to the doctor, orthopedic, saying, can I not get a knee replacement done on this? Similarly, we need to spread the awareness that it is a right of a human being to be comfortable, and ask the doctor, can I just get some comfort care? I do not want aggressive treatment. So as much as we try and educate our doctors and tune them into palliative care, we also need patients to start asking or start voicing their opinion, saying, I want to be comfortable. I do not want 1, 2, 3, 4 things done on me. So automatically it's a situation for the doctor saying, oh, what am I suggesting? This woman doesn't even want it, or this gentleman doesn't want it. So we really need to spread the awareness amongst common people, because what we need to tell them, it is their body, it is their right. Therefore, it has to be their decision of how they need to be treated. It is not the whims and fancies of the doctor. For the patients and the common man to make these decisions, they need to be well informed. Why do you think the society abroad is more okay talking about death and dying? Because they're aware of situations in conditions like, say, motor neuron disease or Parkinson's, where there is no treatment. There is no treatment for chronic renal failure unless you put in a new kidney. Patients keep doing dialysis. That doesn't mean he's going to live forever. But that is not told to them. They feel dialysis karte raho, main jinda rahunga. But the dialysis also, just imagine his quality of life. He's not able to get out of the house. He's not able to get out of the city. Every other day he has dialysis. Dialysis itself causes so many complications. So the point is, in India, I think that Sadayushman Bhava is attributed to always the length of life. It's the quantity of life, how well we live, how less dependent we are. Very often, I think I've told you this in the past, where I've heard my grandfather say every day of his life of anayasena maranam, vina dainena jivanam. to the Lord, saying, I do not want to die suffering and I want to live a life without illness. Yes, not everybody is lucky, but even in that illness, it is the right of the patient to be served the dignity and respect and not let the illness strip him of that, because that's a basic thing for every human being. It's very, very important to maintain that till the end.
Right. Doctor, we have a question from Mr. Shrikant Kulkarni.
Yes.
Says with multiple specialists, nurses, psychiatrists, social service people, etc., involved in palliative care, it must be very expensive. Is that so?
So it's a very important question. So coming to, there are a lot of NGOs in the country which actually deliver free service. In the city of Bombay, we have two NGOs, Romila Palliative Care as well as Jimmy Bilimoria Foundation, PAL Care. These are NGOs, non-governmental organizations, which deliver free home care to patients, because usually our patients are too sick to be transported anywhere. They come in a team of doctor, nurse, and counselor. And if you're able to afford, you can just give a donation. Private palliative care can be a bit expensive, but it is not even 1% expensive of the kind of aggressive treatment that we receive in intensive care units. So, for example, I would just like to quote here what a family said. I had a family who had a 92-year-old gentleman from a very well-to-do family, who the gentleman developed COVID and was in the COVID ICU for about 18 days. This was not even 2 months ago. Finally, the doctors, after 18 days, said that, really, we can't do much. It's better that you go home. The amount of medical bill that family spent for the gentleman was close to some 10 or 15 lakhs. I can test you that if we had this gentleman didn't become 92 overnight. He's becoming 92 for 92 years. If we had a family physician who knew the family well, of course, have conversations with the family and the gentleman of any emergency that comes to you, what would you like to do? Would you want us to fight tooth and nail if it was an irreversible condition, or keep you comfortable? Now, 2.5 years of COVID has taught us that 90 plus, 80 plus individuals with comorbidities do very poorly with COVID, vaccinated or otherwise. There are very few elderly, especially if they get into complications of COVID, like needing oxygen or lung fibrosis, they really don't do well. There's enough evidence to prove that. And therefore, if the conversations had happened well in advance, this gentleman needn't have gone. So a lot of it is preventing that suffering. We do not budget suffering in this country. Putting in the ICU, we feel is, how can I not do this for my parents? We feel guilty about not doing certain things. But ICU is a lot of suffering, and that too for a frail 90-year-old who's alone in the ICU. Somebody's changing him, somebody's cleaning him. There is no familiar touch, there is no familiar voice. It's not his own family. Imagine being in the ICU alone with strangers around you and not even knowing what they're doing, how they're doing, because for them it's a job. And we really need to have these conversations so that whole 3 weeks of suffering could have been avoided. He came home, he was not even in a position to sit up, walk or talk. We sent the palliative care team, simple things. We shaved him, we gave him some physio, we gave him some massage. He sat up, and that was not even 0.01% of this ICU bills. So private is not free, but it is not even half as expensive as what one spends for aggressive, futile, life-prolonging treatments in the ICU.
Doctor, but palliative care is not covered by medical insurance.
So we are trying to, but there has been a body set up to say that yes, we should cover palliative care, especially the first step is for patients with cancer, who are into palliative care. We are trying to get into the insurance companies to say that yes, we need to do. Having said that, suppose you are covered with insurance for, say, admission. You can be very clear that I'm okay to get admitted in the hospital if my son or daughter can get an insurance cover. But It is your right to say, I will get admitted for comfort care. I do not want to go to ICU. I do not want to be resuscitated. I do not want to be put on the ventilator because I know that my condition is so and so. It has to be your right. It cannot be the doctor who is seeing you for the first time in the casualty to decide what he does with your life. It has to be your decision. And that is very important to know. That patients have rights to say no. You have the right to say no to medical care if you are understanding the consequences of that no. It's not that you're just being no. I mean, like, for example, if you're an altered mentation or your altered consciousness or a dementia patient is screeching no, no. But the point is, it's very important to assess the capacity of the patient. And once you've understood the consequence of saying no, it has to be the right of the doctor to respect that decision. It's very, very important.
Doctor, we have a comment by Mr. Shyam Mittal who says it's a wonderful session and you are talking like a saint.
See, no, I don't want, I think, I should also tell you this. It is also life experiences that has taught me this, because I have been on the other side of the table with my parents, and I know the kind of emotional, psychological issues that come along with it. Just like simple things like taking my mother to the dentist. It is a nightmare in the rains. First to make herself ready, then to see to it that it's timed well with her meals. Also the bathroom. There is no bathroom in the dentist. Take her down the lift, into the car, traffic jam. You have to budget so many things. And I can say that I can thank the Lord that I'm privileged and entitled to have these services. But there are so many senior citizens who are left to fend for themselves, who are left to travel in auto rickshaw and buses. It's very hard life. And therefore, we really need to have a society also which is more empathetic. We are living in a highly intolerant society where even if you're trying to get out of the car with a senior citizen, there are 20 people honking away saying, they don't have the time to wait. So the point is, even medical, healthcare has become obviously much more commercial. It has become, everybody wants results like this, and everybody wants to keep their patients alive all the time. That's not going to happen. It is a part of life, and therefore we need to get more realistic, and we need to get to the level of patients and try. I'm not saying live their life, but at least acknowledge their distresses during that period, of the journey of the chronic illness.
Doctor, I'm asking you this question, in public here, but do you think it will perhaps help if there is a legal intervention that happens, where a legal intervention that happens where a doctor may not have advised palliative care, where, and actually she or he should have advised. And perhaps then, if a legal intervention happens, and if a doctor is then fined, penalized, whatever, then the entire medical fraternity will sit up and take notice. Do you think
So, Pradyuman, you just imagine the situation. If suppose I put you in that situation where you have lost a dear one, do you have the bandwidth to, kind of cope with your grief and do the chakkar of our legal courts? Just imagine the bandwidth you need to console yourself, chug along your life, carry your family along with you, to cope with that grief, and then sue this doctor, which is exactly what I'm trying to tell you. We doctors do not realize that inadvertently, unconsciously, we do hurt a lot of people. The point is to go slow and listen to the patients. We really need to do what the patient wants us to do. We can't be saying, in my experience, you should do 1, 2, 3, 4. You are not which is exactly what I'm trying to say. And when you talk about legal actions, the majority of the places where there has been legal action, which is probably the US, the 90% of the cases of legal lawsuits against doctors is because of the poor communication or lack of it. And therefore, I think communication is the key, not just in doctor-patient relationship, across the board in human relationships. Because a lot can be served by communication. The fact that you openly discuss what you feel, how you feel, a lot of misunderstanding, a lot of things shoved under the carpet can be solved. The point is, we really need to be able to communicate and After that, support the patient. You cannot be saying, yes, Mr. So-and-so, you have this, it is incurable, it is progressive. Okay, tata, bye, bye, see you. That cannot happen. Once the patient has been given the news, obviously the life of that patient is shattered. It's changed forever. And it is still the duty of the doctor to handhold and help him collect those pieces. And that's what palliative care does. So that the focus is that the primary specialist should focus on doing what he does best: treat the cancer, treat the COPD, treat the ILD. Let the palliative care team do the handholding. Then it's a beautiful marriage for not just the medical fraternity, but also the patients, because the patients has a go-to person saying, today I'm taking this, but I'm feeling low, or I'm feeling constipated, or I'm feeling more breathless. At least there's somebody to acknowledge their symptoms and address it.
Doctor, is there, and there's a question which has come in, you mentioned about 2 palliative care centers in Mumbai. Are there centers in Delhi, similar centers in Delhi that one can look at?
So IAPC has a full details. In Delhi, there is an article that had recently come out, I think both in Indian Express and Times of India, of Can Support. Can Support has been there in Delhi for a very long time, started by a cancer survivor, Miss Harmala Gupta, and they have teams which go across the length and breadth of Delhi NCR, and they look after patients mainly again with cancer. But during COVID, they did a lot of work of, for example, rescuing people to hospitals, or looking after patients elderly at home who had, the younger people were all admitted in hospitals. So a lot of these things have been done by Can Support. So there are centers across the country.
Doctor, we have somebody, we have Manava Nayan Rao, who says a doctor-patient relationship is essential. Me at 82, a COPD, experienced this. During Corona time, my regular pulmonologist could not be contacted, but a qualified doctor contact didn't have time, explained about medicine. He changed between Omnicortel, Deflixicort, Medril. Thank God I had to see Google. Doctor, we have just 5 minutes left. Any tips that you would like to offer to our people who are watching this, as to what should they do? Is there a call center they can call at in case they are in distress? What should they be doing apart from getting in touch with you?
So I will definitely, what I would like to tell you is, it's very important to meet or have a doctor who communicates well, who looks into the eye, has good eye contact, and describes in detail about your illness. It's okay for you to take a special appointment with the doctor so that he has no excuse saying, I'm running out of time, XYZ. Please understand your illness. Please understand the pros and cons of the treatment. And please understand also the natural course of your illness. What happens in an emergency? What am I supposed to expect? See, patients are also scared to ask because they are not prepared to hear the worst. But it's important for you to realize that if you've taken a treatment, it's not making you better, you must ask the doctor, instead of doing a Google search saying, why am I not feeling the way I did? Or what is going to happen in the few years to come? What all can go wrong with me? Please be informed. That is point number 1. Get all the information you need about your illness from the right sources. The second and the most important thing I feel is, it's best not to shop for doctors, because what happens is, when you keep changing your doctors, you keep going back to point 0 and they keep investigating you. And sometimes patients do that to go to doctors to hear what they want to hear. But certain diagnosis is not going to change. So please don't shop around doctors. Please have a family physician. Everybody must have a family doctor, because you need a doctor at a 2 a.m. and 6 a.m. time. It cannot be the hospital consultants. Very often senior citizens do not have family physicians, and that is quite scary, because suddenly you land up in the casualty and it's like a conveyor belt, and then everything starts, from the ICU, from the casualty to the ICU and the ventilator. Nobody even stops to think, because that's what corporate hospitals are trained. It is 1, 2, 3, 4, and you keep doing without thinking whether it's a 19-year-old or a 90-year-old. Nobody stops and thinks. So you must have a family physician. And the third important thing is, please speak to your children your family physicians, your extended family, or whoever you live with about how you would like to be treated in an emergency. Start thinking about it. I mean, it's important. It's not easy, but having said that, it's important to talk about it so that we, the next generation, know how to treat the senior citizens in the best way, because you know your body best. It's very important to express what you want to do and how you want to do it. So I think it is important to start having difficult conversations about death and dying. Very, very important. Like probably even Lord Krishna said that during his Gita to Arjun. What is important is the journey, and the journey has to be comfortable. Yes, life and death are parts of the same coin, but we need to improve the quality of life till death. And it should not be even 1 hour of suffering for any human being, because it is very, very distressing for those who live on to think of how they must have suffered towards the end.
Doctor, we have one question that has come in. This is from Marjorie Fernandez. I'm supposed to be suffering from ILD, most probably caused by too much of pigeon droppings, but symptoms like wheezing, difficulty in breathing, etc., for which I'm prescribed steroids, sometimes showing up only in the Delhi winter, while I seem to be fine during the rest of the year. I know that ILD is irreversible. Am I suffering from a slowly progressive ILD disease? That's the question.
So, so the point is, it's very difficult, Ms. Fernandez, to actually tell you without seeing your scans, without seeing your lung function test, etc. But if it is diagnosed to be interstitial lung disease, then there is no cure for it. It is a slowly progressive illness. And what is important is pulmonary rehabilitation, which is physiotherapy, chest physiotherapy. And also, depending on your oxygen saturation, whether you need supplemental oxygen, you should see a proper chest physician. And palliatives, I don't think there is a pulmonologist in Delhi who's also a palliative care physician. But if get your email, I can try and find out somebody who will look after patients with interstitial lung in Delhi. I will definitely look at that and send. There is one doctor, Dr. R.K. Mani, who is in Delhi, a senior pulmonologist who also is very pro-palliative, and he also is a legal expert. So he's has actually looked at a lot of medical legal aspects towards palliative care and end of life. So Dr. R.K. Mani is one such person. You can look after, look at his number. He stays in Niti Bagh, and I think he has a clinic in Niti Bagh.
Great. Thank you. Thank you very much, Dr. Rajam Iyer, for this session. As you've heard, people are exceedingly happy with what you've spoken. Though, of course, what you have actually spoken is also worrying, because, the community whom we all respect and whom we, trust would take care of our bodies. There are some chinks there, and that need to be addressed. But always good to have you here. And once, I must inform everybody that we must do a session on caregiving, as we discussed. So soon enough, we will do a session on caregiving where I will request Dr. Rajam Iyer to be there, as well as somebody else who is a specialist in caregiving. So please join us at that time. And thank you once again, Dr. Iyer, for this session. We will be having this session on seniorstoday.in on Monday. And those of you who would like to listen in once again, send it off to somebody who you think will benefit from watching this and hearing this. You could do that. The IAPC website is palliativecare.in, which is PALLIATIVE care.in. You could go to that, and there's a directory of palliative care centers that is available there. Thank you once again, Dr. Iyer, for being here. And we'll be back again next Saturday with our next session of Health Live at Seniors Today. Thank you very much.
Thank you so much, and look after yourselves. I think self-care comes first, and please, in whatever way, it's very important to be happy and safe. That's all we pray for, especially for our seniors.
Thank you very much.
Good evening. Bye.